Welcome everyone. It's my pleasure to introduce what I consider one of the premier orthopedic trauma researchers and a dear friend and mentor of mine, Dr. Gerard Slobogean, joining us from the University of Maryland, where he's an associate professor and the director of clinical research. So this is part of the AO North America installment journal club on young femoral neck fractures. Today, we're going to be discussing Dr. Slobogean's paper published in Injury circa 2015 entitled Management of Young Femoral Neck Fractures, Is There a Consensus? So before we get started into the nitty gritty of asking Dr. Slobogean some details here, I'll just give everyone a brief summary of the paper. So this study was aimed to survey surgeons looking at treatment preferences for young femoral neck fractures. A 17-item survey was sent to 540 surgeons. And it revealed that most surgeons perform open reduction in less than 25% of cases, but that's including both displaced and non-displaced fractures, so keep this in mind. Time to fixation for most cases was less than 24 hours. And for displaced fractures, the preference was split between surgeon preference for cannulated screws or a sliding hip screw device. Interestingly, also, I thought most surgeons reported using both device strategies when treating these fractures in the previous year. So it's really a kind of a gross overview looking at a bunch of surgeons and a bunch of surgeon preferences for managing these injuries. So Dr. Slobogean, we'll just start by asking you a little bit about what the genesis of this study was and kind of what brought about your interest in this topic.
Sure. Thanks again, Lucas. Thanks for the introduction, the kind words, and the opportunity to discuss this topic. As you mentioned, this study was published in, I think, about 2015, but really the work prior to its publication was a few years in the making. And the impetus for the study was multifold. First of all, my mentor, Mo Bhandari, had the FAITH trial underway. And the FAITH trial was an elderly femoral neck fracture study looking at cancella screws and sliding hip screw. And so we recognized that, even once we solve that problem, young femoral neck fracture patients are very different than elderly patients. So we wanted to dive into that a little bit more. And I took a particular interest in that coming off my own high energy trauma fellowship. The other thing that we really noticed was in preparation for what we were going to call the FAITH 2 trial, which was the same study, but in young femoral neck fractures, that there was sort of a growing change in North America in terms of how surgeons were wanting to approach these fractures. Previously, both documented by Dr. Bhandari in a previous survey and also just in my own experience, the vast majority of these injuries were treated with closed reductions and multiple cancella screws. And then slowly over the years at the OTA and within our societies and things like that, you would see that more and more surgeons wanted to treat these with open reductions and fixed angle devices. And Liberace published a paper, I think maybe 2009, 2010, somewhere around there in JBJS that really showed much better results with fixed angle devices. And I think that continued to really drive this move to changing implants. And so really there was a lot of equipoise or at least controversy in there. And we wanted to survey a wide network of surgeons to figure out what they were doing at the time.
And was there any specific finding in this study about surgeon preference that surprised you or something that you didn't anticipate going into releasing the survey?
Well, I think the two things that were notable for me was, again, the previous survey by Dr. Bhandari and just my own experience, which was the vast majority of these were treated closed with cancella screws. And then, 15 years later, you repeat the survey and now you're seeing a much larger proportion of people using fixed angle devices and open reductions. So I think that was probably the most notable finding there. The other thing, sorry, that I want to mention is this survey was actually of a bunch of different orthopedic surgeons, not just North American surgeons. So there were some international surgeons in there too. And I think that the international community didn't jump on open reduction with fixed angle devices as aggressively as North America did.
Yeah, you kind of in the results of the paper, you guys break down surgeon preference by a variety of things, by surgeon experience, whether they were North American based or international. And there are a couple of interesting findings. And I think you're accurate that the group of surgeons that responded, the non-North American group of surgeons that responded, were less likely to perform open reduction. So you survey essentially on kind of three important factors. I mean, you ask a bunch of questions. Like we said, it was a 17-item survey, but I think the three things that we're going to talk about during this journal club, and the three things people consider kind of important topics when it comes to the young femoral neck, are kind of method of reduction, so open versus closed, your implant choice, whether that's multiple screws or a sliding hip screw, and then the timing of reduction. Is this a surgical emergency or a surgical urgency? And I'll just ask you kind of a little bit about your own preferences, because I know you've done a lot of thinking. You've published kind of a series of work on the young femoral neck. And so I'd ask you a little bit about your method of reduction, your implant choice, and timing of reduction, and how you see literature kind of supporting your decisions in that regard.
Yeah, no, thank you, and thanks for highlighting, you know, as you mentioned, a body of work that we've done with all of our collaborators, lots of North American sites with McMaster University, and really, I think what I'm going to describe, it describes my evolution and sort of 10 years of research in this topic. So I think the first thing to mention is that probably the number one predictor of your outcome is going to be your reduction. Now, that, in my opinion, based on the literature, is really still based on radiographic reduction. So I am not dogmatic that you must do an open reduction. I think if you can get a radiographic good reduction, then that is sufficient. That is a reduced fracture. And I think the work by Sam and Joe Patterson, I think was really helpful in that it showed that there is probably a cost to open reduction, all things being equal. So I think, number one, you got to get it reduced. My preference is to try a closed reduction first. If not, then I'm going to proceed to an open reduction. And in the really high comminuted, highly displaced fractures, a lot of those are getting open reductions. The second thing, I mentioned that first, but you know, the next part is the timing of that reduction. Because the reduction is most important, I think you want to have your best surgical team. I don't think you want to be tired in the middle of the night when you're more likely to accept an unacceptable reduction. So for me, timing has become less important. There's been other papers that have sort of supported that as well. And so I'm trying to do these within 24 hours, but certainly during the daylight. The next thing then becomes the implant. My implant choice has evolved, and it continues to actually be a little bit of a dichotomy. So I think both types of implants, fixed angle and multiple cancella screws, have benefits. And ultimately, I think in many senses, you're picking your complication that is acceptable to you and the patient, right? So what we know from the elderly faith trial, what we know from young femoral neck data and multiple publications now, is that each has their own complication pattern. So cancella screws, they're not very stable for shear, right? So they are going to fail in varus collapse and screw prominence. Sliding hip screw or some sort of other fixed angle device, it's going to fail with cutout. And because of that, depending on the patient population you're dealing with in the young femoral neck bucket, that complication can be very different. So in a 20-year-old, screw cutout is a huge problem. That now is a total hip. In a 45-year-old, that may not be as much of a problem. So the way I approach this now is, for the young patient, like I just mentioned, the 25-year-old patient, I'm going to give them cancella screws because I think that their bone quality is tougher. So a sliding hip screw may actually spin the head a little bit more. I think that a smaller diameter screw may decrease the risk of AVN. There's some data to support that. And most importantly, if they collapse in varus, that's an easy problem that I can deal with. Conversely, if they're 45, for example, I think that their bone quality is probably a little less strong. They may have a little more comminution. They may need more vertical shear resistance. So a fixed angle device is probably better in that regard. And again, if it cuts out at 45 years old, a total hip arthroplasty is not, a life sentence. So that's how I now view it, is sort of based on which complication is still tolerable and what is most likely that they need. And then lastly, I would say, given all of that, I'm very, very interested in some of the new implants that combine perhaps the best of both worlds, things that have multiple small diameter screws, but are actually fixed angle. And in Europe, the Targan device has a long track record now of really good results. And in North America, the devices that we have brought to market have really struggled. And there's been at least 3 major devices in the last 10 years that have come to market in North America that have all been pulled, 2 in the last few years. And there's 1 device that remains that seems to be having some promise, and that's a single screw with a derotation screw, all fixed angle. It allows some collapse, smaller diameter than the sliding hip screw. And being on the OTA program committee, spoiler alert, for the 2021 meeting, there's going to be at least 1 or 2 case series presented with some pretty good results. So I'm excited about that.
That's awesome. Thank you so much for sharing your thoughts. Like I said, you obviously have a body of work here, which means not only do you know the data from the publications that you've been part of the authorship on, but also all of the publications you reviewed to write those papers and to come up with those grants and everything. So it's really helpful to get your insight on sort of those kind of, like we talked, those 3 big buckets of treating the young femoral neck, because I know you've thought about it probably more than the average traumatologist. So we're grateful for you sharing some insights and also joining us for this. And then the next part of this will be a live Q&A. And so hopefully if people have more questions, this will generate some discussion. And the Moorshed paper that you talked about, closed versus open reduction, is another paper that will be part of this journal club. So hopefully we'll get into some more details surrounding the femoral neck. But again, want to thank you for your time and sharing your expertise on the topic.
Awesome, Lucas. Thanks again for the opportunity.
All right, guys.